Many thanks, Adiba. It's my pleasure to present on behalf of the entire second-line study group the results of an analysis of baseline resistance, virological failure and emergent resistance in the second-line randomised controlled trial. These are my disclosures. So we know that antiretroviral therapy failure is associated with drug resistance. The World Health Organization recommends that we should be using a boosted protease inhibitor and 2 nucleoside or nucleotide analogues, and for the purpose of this presentation I'm going to use the word nucleoside from here on in for those 2 possibilities. Upon failure of a standard recommended first-line regimen, which consisting of a non-nucleoside analogue combined with 2 nucleoside analogues. Because of the recycling of agents from the nucleoside class and the potential for cross-resistance, there is interest in implementing wider access to genotypic testing to optimise the selection of the nucleoside backbone. So in the second-line randomised trial, we took people who reached out a definition of virological failure of a standard recommended non-nucleoside and nucleoside first-line regimen, and we randomised them to a WHO recommended regimen which consisted of ritonavir-boosted lopinavir with 2 or 3 nucleoside analogues. At the time we designed the study, 3 was actually 2 or 3 was the recommendation. And we compared that to a group we randomised to a nucleoside-sparing regimen of 2 agents, being ritonavir-boosted lopinavir and raltegravir. The results of that study we presented and published the primary week 48 report in the IAS edition of Lancet last year, and we found that the raltegravir arm, the nuke-sparing arm, was non-inferior to the nucleoside arm. We also presented the final week 96 follow-up data at CROI of this year with the same result. So in this sub-study, our objective was to examine the contribution of baseline nucleoside resistance, as well as other potential predictive variables being demographics, medical, HIV, and antiretroviral therapy history, as well as antiretroviral therapy adherence, as variables for prediction of failure, of virological failure on study. We used a definition of virological failure at a threshold of 200 copies per mil in plasma, and the samples that we used for this analysis were all measured in a central laboratory in Sydney. We performed genotypic antiretroviral testing on those samples using the ViraSeq genotyping system for reverse transcriptase and protease in one kit and integrase in a separate kit. We defined adherence, which we'd measured in the parent study, using a validated 7-day recall instrument in which patients had to document whether they'd taken all, most, half, very few, or none of their antiretroviral therapy. And for the purposes of this analysis, we chose to categorise that in a binary fashion as either all or less than all antiretroviral therapy taken, and the adherence tool was administered at week 4 and week 48. From the point of view of constructing scores, we considered 2 scores. The first score that we constructed, we named the Global Genotypic Sensitivity Score, or the Global GSS. And this we defined as the combined score for sensitivity of the patient's virus isolate to lamivudine or emtricitabine, abacavir, zidovudine, stavudine, dodanosine, and tenofovir. So in that case, a maximum score would be 6, and if you have a maximum score of 6, it suggests you're highly sensitive to all those available nucleosides, and therefore there being no resistance. In order to construct that score, we used the Stanford algorithm, and that was based on HIV database version 6.3.1. The second score we constructed was specific, so a specific genotypic sensitivity score, and it was specific to the nucleoside analogues that the patients were prescribed to take in the nucleoside arm of the study. We only constructed it for that arm because, of course, the other arm was nuke-sparing, and the maximum score might be 2 or 3, depending on how many nucleosides were given by the site, were prescribed for that patient. We perform multivariate logistic regression analysis to assess the predictors of virological failure. So just to recap the parent study, we enrolled adults with confirmed virological failure of non-nucleoside and nucleoside standard first-line regimen at a threshold of 500 copies per million plasma. Patients were not allowed to have had prior exposure to protease inhibitors or integrase inhibitors. 541 patients were randomised 1-to-1 to each arm, and the primary objective was to compare the proportions of patients with plasma viral load less than 200 copies after 48 weeks of therapy. It's important to note for construction of the nucleoside backbone in the nucleoside arm is that there were two options given to the sites. If they had genotypic resistance testing available, they were allowed to use that and use that result to construct the backbone. If sites did not have that available or chose simply not to use it, they basically followed a very simple algorithm which suggested that if patients had become on a thymidine-containing analogue, then they switched to a tenofovir-containing regimen, and vice versa. And if the sites believed there were indications to add a third drug, they could do that. So looking at the baseline characteristics of the cohort, we enrolled 541 patients in our intention to treat analysis with a median age of in their late 30s. They were 55% men, 45% women. They were predominantly Asians, mainly enrolled from India, Thailand, Malaysia and Singapore, and Africans enrolled in either Nigeria or South Africa. They were fairly late in their disease stage. Nearly half of them had received an AIDS diagnosis in the past, and their median CD4 count at baseline was 190. They had a median log viral load level of 4.3, and they'd been on a duration of therapy was a median of 3.5 years on first-line therapy. Just to give you a little bit more nuance in what we used for the nucleoside arm, what was administered in terms of nukes. Genotypic resistance testing we used to construct the backbone in 73% of patients. 2 nukes were used in 77% of those patients. Tenofovir was used in 81%, a cytosine analogue in 87%, and zidovudine, or AZT, was given to 45%. Here's the diagram just outlining the study disposition for you. So we had 541 patients at the top there in our intention to treat analysis. Of those, we had 491 for whom we were able to characterise resistance. And at week 96, we had 451 patients who reached the week 96 endpoint. So to the results. This slide and this figure demonstrates the distribution of the baseline global sensitivity score, or GSS, by treatment arm. And the raltegravir arm, by the way, for these slides is indicated in the brown colour. So what you will see here is that, on the x-axis we've characterised, rather than use the score, I've characterised high, moderate and low resistance here, and just to sort of tease that out and make it explicit, if you've got high resistance you'd have a low score because you're less sensitive to the available analogues, and vice versa. So if you've got a low score, you're likely to be pretty sensitive. You will be more sensitive. What you'll see is that we've got a pretty good distribution of degrees of resistance across both arms, and you'll also note that the majority of patients had high levels of resistance to nucleoside analogues, indicating a lower score. If you then take those patients and express their outcomes at 96 week by virological failure or success, this is what you see. And just to orient you, the top bars indicate those who had virological failure, and the lower level of the bar indicates those who were successful at 200 copies per mil, remember. So what I think you'll see here, and I hope you agree, that the most striking finding is that the patients that had the greatest degree of virological failure, which is on your left, seem to actually have low levels of resistance to the nucleoside analogues, perhaps somewhat paradoxically. If you then go and look simply at the specific score, so remember this is the score we constructed for patients depending on the nucleoside regimen actually prescribed to them, again you see a similar pattern, not profound as for the global score, but nevertheless there does seem to be an association for people having low-level resistance and therefore more sensitivity to the nucleoside backbone compared to those with high resistance and less sensitivity. So moving on to the multivariate analysis of predictors of virological failure over 96 weeks. And what I'm going to show you here are simply those variables that remain significantly statistically associated at 96 weeks. I'm not going to show you all the univariates because it would be a terribly busy slide. So we found that the study population was associated with virological failure at 96 weeks. And using the Asian population, remember these are predominantly from India and Thailand, and also Malaysia, Singapore, that Caucasian participants, Hispanic participants, and African participants had a greater odds ratio of failing at 96 weeks compared to those Asians. We also found an association with baseline viral load. Those with a lower viral load at baseline were less likely to fail than those with a higher baseline viral load. Remembering we stratified at a level of 100,000 copies per mil or log 5. We also found an association with adherence, and that was at both our early measurement of adherence, which was done at week 4, and also late at week 48. And remembering we categorised this in a binary fashion, so those who did not take all of their antiretroviral therapy in the prior 7 days were more likely to experience virological failure than those who had taken all on self-report. We also found that the global genotypic sensitivity score was associated, perhaps not surprisingly given the figure I showed you just a minute ago. And again, there was a paradoxical association in that those with low resistance and therefore a higher score were more likely to fail than those with more resistance at baseline or high resistance. So, by way of summary, with virological failure in this study, this sub-study of the second-line trial was associated with self-reported non-adherence, with a higher baseline global genotypic sensitivity score, a baseline viral load of greater than 100,000 copies per mil in plasma, and also race. And in conclusions, we believe these research findings have implications for HIV treatment and care programs worldwide, and they support a greater investment in the research and understanding and implementation of effective adherence interventions and support. We believe there should be less emphasis on the basis of these results on implementation of expensive and complicated antiretroviral resistance testing technology. I'd like to thank all the many people who contributed to this study, as well as the parent studies and other associated sub-studies, particularly the writing committee, the project team, the site investigators and staff, our study partners, and of course the study participants. Thank you for your attention.
Thank you, Mark. Microphone 3.
Mark, there's a very nice and much anticipated data over here. Dan Kritzkas.
Dan, yeah.
The result, although counterintuitive, is consistent with what several other groups have shown, that less resistance at baseline, higher virus load at baseline implies low adherence at baseline and predicts future low adherence. But I would question your final conclusion about these data arguing against the implementation of resistance testing, because the use of resistance testing could identify subjects who are not resistant to their less expensive first-line regimen and could be cost-saving in averting the use of a more expensive second-line regimen.
Yeah, Dan, look, I think that's a fair comment. I guess, in considering these results, you're right. I think that genotypic testing in that sense could be cost-saving because you could identify people who are about to be switched unnecessarily to second line, and obviously they would require a package of care that involved more working out what's going on with taking their medicine. So I think that's a fair comment. I think it would need to be targeted in some way in order to reduce costs, but I think that's quite reasonable, yes. I should add, I don't think that should come at the expense of trying to figure out exactly why some people, despite telling us otherwise, often, clearly aren't optimally adhering to therapy. And, we've been trying to do that for a long time, and we're, I think, still struggling to find the best means of doing that.
Yep. Hey, Mark, Joe, you're on. You could argue that it could be actually very, very simple, and to do something like just look for 184V. So not some really complicated resistance test, but essentially looking for the absence of resistance, not the presence of resistance. And so a simple test that would measure 184V, either like a simple amplification test or a probe test would fit. And then those that didn't have that resistance mutation would then be subject to the adherence package, as you were talking about.
Yeah, I think that's also quite reasonable, Joe. I mean, I guess at the moment, part of the problem with, this sort of molecular technology is it's very difficult to implement at point of care. And I mean, we've been hearing things about that at the conference, and that's very hopeful. I guess my concern, and perhaps our concern, is that at current times, you really need to implement, probably in central laboratories, quite expensive and demanding testing. And if that were then implemented at the expense of perhaps some more practical field type of tools in order to try and identify those people, then that would perhaps not be money well spent. But I take the point that if we had that capacity, particularly point of care, that might well be useful.
David? Oh, yeah. David Stanton, USAID. I'm curious about the finding of the independence of race as a predictor of viral suppression. And early on, you didn't identify that subset of your population by race, but by geographic origin, which is Africa. So the question is, did you look at viral subtype as a possible predictor of virological failure?
Yes, we did.
What did you find?
I mean, we did mention we were looking at demographics, so I guess we considered the populations under that. Yeah. We didn't find any association with subtype.
You did not, okay.
None.